Good evening, America.
Welcome to 3600 Seconds. We begin tonight with revolutionary new treatments for the brain cancer glioblastoma multiforme.
Our resident doctors here at 3600 Seconds, T. Alpheus Ulysses Remington V,
and Mike compiled information about the cancer and its newly arising treatments. Glioblastoma multiforme is the most common adult form of brain cancer. Like all cancers, it is tumor-based and not yet curable. All known treatments to this point are both potentially harmful to the patient and do not fully cure the disease.
Glioblastoma multiforme has a survival rate of just over 2% over 5 years in patients over the age of 45. It has been labeled by many as the most aggressive of any cancer.
Other forms of brain cancer include neuroblastoma, a cancer of the nerve cells commonly observed in children and infants, pituitary tumors, tumors on the pituitary gland that can affect men and women in their 50s to 80s, but are generally benign, and astrocytoma, which encompasses a wide range of malignant brain tumors, including glioblastoma, which is an example of astrocytoma in its fourth stage. Our research in this episode will be focused on glioblastoma and the quest for its cure.
Once diagnosed, the life expectancy for a patient suffering from glioblastoma is less than 1 year, and only 6 out of 100 patients live for more than 5 years after their diagnosis. Symptoms that may indicate glioblastoma include nausea and headaches, memory loss, personality changes, seizures, or changes in speech, vision, or hearing. The most prominent current treatments for glioblastoma, like those for many other cancers, include radiation therapy and chemotherapy. Chemotherapy is meant to kill rapidly dividing cells, which is one of the main properties of cancerous cells. This is a problem, however, because bone marrow cells, digestive tract cells, and hair follicle cells are all killed in the process. Some drawbacks of radiation are that it is capable of causing cancer on its own, and that it is an inherently dangerous process in itself.
Another potential treatment from the past was polycephin. This was a chemical compound meant to inhibit tumor growth by preventing DNA replication. It never reached a phase during which it could be tested on humans, however. XL-184, or cabozantinib, is a treatment that has gained great traction in the medical world in the past year, and very few studies about the treatment have been done to date. One study of the treatment on 46 patients showed that 38% of patients experienced a 50% reduction in tumor size. This is a promising new treatment which can potentially be used as an alternative to current treatments in the future.
Carmustine is a drug that is administered intravenously and is used to treat many cancers, including glioblastoma, non-Hodgkin's and Hodgkin's lymphoma, and melanoma. One recent study of carmustine that tested 29 patients elicited a response by 55% of these patients in which the tumor was stabilized. In another study, carmustine was tested in parallel with erlotinib and temozolomide. In this study, carmustine was administered as an established treatment, so its results could be compared to a new treatment, erlotinib.
Novocure's Novo-TTF appears to be the most prominent of the new glioblastoma treatments. Novo-TTF delivers electric fields called TT fields to the brain using transducer rays from electrodes in a helmet-like device. It is portable thanks to a portable battery and is therefore the most convenient. In a study done in May of 2012 on patients with a median age of 54 years, researchers found that the median lifespan had increased by 0.6 months over the previous 6-month lifespan. However, this study is most promising because the free survival rate at 6 months went up from 15.1% with chemotherapy to 21.4% with the Novo-TTF.
Clearly, this treatment is promising because it extends the expected lifespan of people suffering from glioblastoma. Additionally, it improves the quality of life for these people because they do not need to expose themselves to harmful rays or dangerous drugs. The following video from NovoCure details what Novo-TTF does on a cellular level. In the following films, we see two identical cultures of cervical cancer cells followed in time-lapse under the microscope. The culture on the right is an untreated control, while TT fields are being applied continuously to the culture on the left. The first difference between the cultures appears about 2 hours after treatment starts. No cell divisions are seen in the TT fields treated culture, whereas in the control culture, cells have already started to divide. It takes 12 hours for the first cell to round up for mitosis in the treated culture. In addition, cell cleavage is delayed and takes 3 hours to finish. The next difference between the cultures is that in the treated culture, cells round up for mitosis. However, they are not able to complete the normal division process at all. They remain arrested in mitosis for about 5 hours and then die through programmed cell death. This mitotic arrest and apoptosis is seen in dividing cells only. The dying cancer cells in the TT fields treated culture exhibit membrane blebbing, the hallmark morphologic characteristic of programmed cell death, also known as apoptosis. After almost 2 days of TT field treatment, the difference between the control and treated cultures is clear. Cancer cells fill the entire available space in the control culture, while in the TT fields treated culture, only those cells that did not attempt to divide remain alive.